Hi, my name is Taylor Reed. I'm from the University of Toledo, and I will be presenting my poster called Shedding a Light on Primary Progressive Aphasia. The reason I chose this topic was because when I was doing my clinicals at the University of Toledo, I was fortunate enough to work with a client that was diagnosed with primary progressive aphasia, so I just wanted to bring more awareness to this topic. Primary progressive aphasia, also known as PPA, is defined as a language-based dementia with a gradual deterioration in comprehension and producing language abilities. So it was first termed by Marcel Masulam in 1982, so it is relatively new, and there are three different types: agrammatic or non-fluent, logopenic, and semantic. So by the end of this presentation, my viewers will be able to identify primary progressive aphasia, identify the phased treatments for logopenic primary progressive aphasia, and determine evidence-based practice therapy treatments. So PPA does occur in less than 200,000 individuals in the United States, so it is rare. The symptoms do start with word-finding difficulties and then progress to deficits in syntax, semantics, and sentence processing. Dysarthria and/or apraxia can also accompany PPA. And then in the beginning stages, a lot of clients actually mistake PPA for just stress or anxiety from work or home life. The cause of it is a degeneration of nerve cells in the left hemisphere in the areas of language, and it cannot be correlated with any other cause or disease. So a diagnosis is usually confirmed from an MRI, and it's usually after a 2-year decline in the individual's language abilities. The next part of my presentation, I will be discussing the phase treatments, and this is for logopenic primary progressive aphasia. So for the phase treatments, the treatment will be similar to stroke-induced aphasia treatment, but you're going to use a phased treatment because of the decline of primary progressive aphasia. So during this, you just want to do frequent evaluations to determine where your client is and if you need to go to that next step in treatment. So the three phases are mild, moderate, and severe. So phase 1 is mild. This is where the individual will use more general terms. For example, they'll say fruit instead of an apple. They may mispronounce words by adding in an extra letter or substituting one. Family and friends will still be able to understand them, but they will have impaired working memory. So during this phase, the clinician really wants to collect that baseline and then repair any deficits, because research actually shows that by repairing those deficits, it could decrease the degeneration. And make sure you use frequent words that the client will be using either in work or at home. Phase 2 is considered moderate, and this is difficulty in recalling common and uncommon words. And the patient will start to use an increase in generic terms, so they'll start to say things, stuff, instead of being more specific. This is where an additional cognitive deficits come in, and this is where you want to introduce the multimodal communication and an AAC device, whether that be a Tony Dynavox or just something simple as a communication book. And you really want to use the communication partner in this therapy because you want them to be able to use this with the client outside of your session, because that's really where it's going to be important. So phase 3 is severe, and this is where it's a huge increase in that cognitive deficit. So you're going to shift the focus from the individual to actually training the communication partner in the individual. So you're going to really increase those nonverbal communications. So definitely increasing those gestures, drawing, spelling if the patient's still able to, and teaching the communication partner to lead the conversation, but also allow more time in response. That way it takes away a little more anxiety and stress for the individual. And unfortunately, at the end of this, you might have to train a skilled nursing facility if the patient does go there. Train those employees on the patient's AAC device, and then also educate them, let them know that they need to provide the patient with a picture schedule. This will really increase the functional communication and decrease any stress for the patient. So some resources are definitely using that lexical retrieval training. Semantic feature analysis is the one that I recommend. For my client, we laminated little cards and then cut them up and actually put them on a key ring, and he added that to his car keys. And then that way, when he couldn't think of a word, he could flip through that and be able to describe the word or use gestures to be able to recall that word he was having difficulty with. So definitely recommending those gestures, writing, drawing. Some software or apps that are great is Aphasia Software Finder. You can find that online, and you just go through and really find where the individual's deficits occur, and then they recommend apps. Constant Therapy is an app. It's a 30-day free trial. It's great for any patient with aphasia, but really great for that phase 1 of primary progressive aphasia patients to really repair those deficits. And TalkPath, it's a website. It was produced by Lingraphica, and it really has a lot of therapy activities that the patient can do at home. So in conclusion, yes, primary progressive aphasia therapy and stroke-induced aphasia therapy are going to be very similar. It's just really continuing those evaluations and determining the client's current level of communication and going through those phased treatments. And really just tailoring the individual sessions to that client and where they are in the phases. And finally, I want us all to remember that we do have the tools. We possess all these tools that are needed to maximize communication and quality of life for the clients and their families. We just need to be aware of them. So thank you for listening to my presentation, and I hope you learned more about primary progressive aphasia.